Good evening, everyone. Welcome to the BNet webinar, 9th webinar. So today we'll be discussing on bare essentials of multiple sclerosis. For this webinar series, I like to invite Professor Sharma, Senior Consultant Neurologist at St. John's Medical College. He is my teacher and has got a depth knowledge of all aspects of neurology. I welcome him to chair this session. And also I welcome all the speakers, Dr. Rajesh Iyer, Senior Consultant Neurologist, who is an epileptologist, have got a special interest in multiple sclerosis from Vikram Hospital, and Additional Professor Netra from NIMANS. She is actually head of unit which is treating multiple sclerosis and other demyelinating disorders. And Dr. Savit Kumar, he is a interventional neuroradiologist and who is working at Apollo Group of Hospitals, and also our postgraduate student Rohit, who is going to present a case. And I would like to hand over the mic to Dr. Michael D'Souza. He is a INTAS professor, divisional head of the group which markets this multiple sclerosis drug. Over to him to give a brief introduction.
Good evening, respected doctors. At the onset, I would like to thank the Bangalore Neuro Education Trust for giving INTAS an opportunity to be a knowledge-sharing partner in today's webinar entitled Bare Essentials of Multiple Sclerosis. INTAS, the 9th largest pharma company in India, has evolved into a responsible global pharma company, spearheading several knowledge-sharing initiatives, which is crucial for a research-based pharmaceutical company like us in providing quality drugs and novel treatment strategies for your patients' benefit. We have, through our close association with the medical fraternity, launched in recent past for the treatment of your multiple sclerosis patients, difira, dimethyl fumarate, and merosia, terifluramide, which shows our commitment to all your MS patients. I wish all the success to Dr. Raghunandan and Dr. Sharma, and the host of eminent neurophysician panelist of Bangalore Neuro Education Trust, and the speakers in today's program in organizing this webinar for the better clinical management of multiple sclerosis patients. Thank you very much. Thank you to the Bangalore Neuro Education Trust for this webinar. Thank you.
Dr. Raghu, can I start the proceedings?
Raghu, you're muted.
Yeah.
Okay, can I start the proceeding, Dr. Raghu?
Yeah, I will hand over the mic to Professor Sharma to start the proceedings. And also I welcome all the delegates, all the attendees, as well as the panelists for this talk. Over to you, Dr. Sharma.
Thank you, Dr. Raghu, for the kind introduction, and thank you, BNet, for inviting me to chair this session. First of all, I'd like to congratulate BNet for organizing such wonderful academic programs. As Dr. Raghu has already informed, the first presentation will be by Dr. Rohit, who is a postgraduate senior resident of neurology in St. John's Medical College. He'll be presenting an interesting case of neurological disorder, and the panel will be discussing the differential diagnosis. Dr. Rohit.
Good evening, everybody. I'll be presenting the case now. Is my screen visible?
Screen visible. The last slide has come with.
Yeah. Good evening, everyone. So I'll be presenting the case of a lady who has presented with imbalance and then a visual loss for the past 15 days. So here goes the presentation. So she's a housewife, and then her chief complaints being imbalance while walking for the past 15 days, and blurred vision in the right eye with mild eye pain on moving for 2 weeks. So she had a slippage of chappals while walking, and after 4 to 5 days, she developed a difficulty in guiding the foot into the mouth and draping the sari. Since 1 week, she also noticed numbness in both hands and both lower limbs from foot till thigh. She had cotton wool sensation while walking. She was able to lift the arms without any difficulty. There was no difficulty in gripping the objects. There were no behavioral disturbances or memory lapses. There was no deviation of mouth angle or slurred speech or swallowing difficulties. No prior history of any fever. No loss of consciousness or any seizures. There was no bowel and bladder disturbances for her. So this is the history of presenting illness. Coming to her past history, she's diagnosed recently with diabetes mellitus, for which she is on oral hypoglycemic agents. Personal history, she's married for 5 years and she's being evaluated for the infertility in an outside hospital. She doesn't have any addictive habits, sleep is sound and appetite is adequate. So treatment history wise, only oral hypoglycemic she's taking for the diabetes. There is no native medication intake or Ayurvedic medication. Coming to the examination, her general physical examination was uneventful. A pulse being 100 beats per minute, which is regular in rhythm. Blood pressure of 120 by 80 millimeters of mercury, right arm supine position. A respiratory rate of 18 cycles per minute, and temperature afebrile. Coming to the systemic examination, her systemic examination was also uneventful. And the central nervous system examination, her higher mental functions were normal. Cranial nerve examination involved reduced visual acuity, that is 6 by 36, and RAPD with impaired color vision with normal fundus. Right eye vision was normal. Extraocular eye movements were normal. No nystagmus, and other cranial nerve examinations were normal. Coming to the motor and sensor examination, so there was no muscle wasting noted as such, and power being 5 by 5 in all limbs, and deep tendon reflexes being brisk, and equivocal response seen in the bilateral plantar, and coordination impaired bilaterally. So her tandem gait was abnormal, and sensory examination was inconsistent with impaired time vibrations in the lower limbs. There were no signs of meningitis, and examination of the cranium and spinal cord spine was normal. So coming to the clinical diagnosis. So first comes the coming to the neuro deficits. So with the history and detailed clinical examination, she was found to have left eye retrobulbar neuritis, bilateral pyramidal signs, and posterior column abnormality. So localization, it was mainly left optic nerve and the long tracts, which was a multi-axial, and pathology. So inflammation mainly secondary to infective bar demyelinative bar vasculitis. So etiologies, we thought of multiple sclerosis or MOG or neuromyelitis optica and other related multiple sclerosis mimics. So we have planned the diagnostic investigations after the clinical evaluation. So we proceeded with MRI brain and spinal cord with contrast, visual evoke potentials, NMO and MOG antibodies, CSF study, ANA profile, ABLA profile, and ACE levels with HIV and VDR. So after getting the MRI done, so we found that the diffusion weighted imaging showed restriction in the bilateral periventricular regions, with the ADC mapping showing no reversal. And the T2 flare showed hyperintensities in the bilateral cerebellum and periventricular regions, juxtacortical lesion, which is shown indicated by a red arrow. And in the contrast, there were lesions which were enhancing in the bilateral periventricular regions. In the spinal cord, the plane showed, so you see the axial sections of the spinal cord showed peripherally distributed lesions. And the contrast showed enhancement in the same regions. So what is the diagnosis? Question, please. 30 seconds for the question. So the highest voting went for the multiple sclerosis. So there was only single attack. So she presented with a single attack since 15 days, and then associated retrobulbar optic neuritis was there, and multiple periventricular and juxtacortical lesions with enhancement was present. So almost all of the lesions were enhancing, so which indicates that all the lesions were of single time. So proceeding with the further slides. So initially we had a differential diagnosis of multiple sclerosis, NMO, MOGAD, or connective tissue disorders. So we proceeded with the investigations. So LPCSF was showing a lymphocytic pleocytosis, total counts of 60 cells with predominantly lymphocytes, and glucose, CSF glucose, which was 167, corresponding the serum glucose was 257, and proteins were mildly elevated, and ADA was normal. And NMO and MOG antibodies, which were sent, turned out to be negative. Angiotensin converting enzyme levels were normal, and HIV and VDRL were negative. So further, we have sent for the oligoclonal bands, which turned out to be negative. And however, because the enhancements were there, we have sent for the gene export, which was negative. And then as per the connective tissue disorder workup, ANA turned out to be positive, and immunoline profile, which was positive for RO52 antibodies, and APLA, which was positive for the anti-cardiolipin antibody. And the visual evoked potentials were prolonged in both eyes, and complement 3 and 4 were normal. So coming to the diagnostic criteria established by Thompson et al. 2017. He has mentioned as a number of clinical attacks and then additional data with dissemination in space and time. If we go through this, so if there are more than or equal to 2 clinical attacks and the number of lesions with objective clinical evidence more than 2, it's diagnosis of multiple sclerosis established. In case of more than or 2 or equal to 2 clinical attacks with number of lesions being 1, additional data also not required, can proceed with multiple sclerosis. And with 1 clinical attack with more than 2 or equal to 2 lesions, so dissemination in time demonstrated by additional clinical data, additional clinical attack, or by MRI or demonstration of CSF oligoclonal bands is required. In case of 1 clinical attack with 1 number of lesions, dissemination in space demonstrated by additional clinical attack implicating a different CNS site or by MRI, and dissemination in time is required, or demonstration of CSF specific oligoclonal bands. So the magnins, the MRI criteria in the multiple sclerosis network established a disease dissemination in space by detecting involvement of at least 2 of 5 following areas of CNS. That is a periventricular of more than 3 or more than or equal to 3 lesions, cortical juxtacortical lesions of more than or equal to 1 lesion, infratentorial equal to or greater than 1 lesion, spinal cord of greater or equal to 1 lesion, optic nerve greater or equal to 1 lesion. And in dissemination of time can be established in one of 2 ways, with a new lesion when compared to a previous scan, irrespective of timing, established by T2 bright lesion and or gadolinium enhancement, or presence of enhancing lesion and a non-enhancing T2 bright lesion on any one scan. So we had established the points in favor and points against for the multiple sclerosis in our case. So points in favor were evidence of 2 lesions with objective clinical evidence, left optic neuritis, visual evoked potentials were prolonged. The points which were against were a single clinical attack, lesions of same time, absence of oligoclonal bands in CSF, ANA positivity, APLA positivity in anti-cardiolipin antibodies, and lymphocytic pleocytosis in CSF of cells of more than 50. So acutely, we have given pulse dose of methylprednisolone for 5 days, and further management of the patient. Question, please. So the long-term plan was necessary to establish. So 30 seconds for the MCQ. So equal number of votes for the azathioprine and interferons. So we went ahead. So we have actually given rituximab for the patient after preliminary workup. So 1 gram of rituximab was given and she tolerated well. And prednisolone was slowly tapered and continued. So later on follow-up, she has clinically improved. Her vision has improved to 6/6 and the steroids were tapered and stopped. And last follow-up was 4 weeks back with no further symptoms. So plan was to repeat the imaging and further dosing of rituximab for her. So coming to the when we have gone through the points against the favor, where APLA was positive and also ANA antibodies were also positive. So we have gone through the literature where we have found 2 studies. So in one study, there was showing a presence of APLA, including both beta-2 glycoproteins and anticardiolipins, presence in multiple sclerosis. And in ANA antibodies also presence in multiple sclerosis. So in this study, out of 147 patients, 22 patients were turned out to be positive, and eventually the positivity has reduced on follow-up. So the another study, the picture of CSF in multiple sclerosis, so which was showing that in case of multiple sclerosis, only mild pleocytosis was observed in 50%, and less than 50% is seen in almost 98% of the patients. However, in our patient, there was 60 cells, and protein usually which was expected to be normal, it was slightly elevated in our case. And also the cytology was predominantly dominated by the lymphocytes, and immunoglobulin oligoclonal bands were negative, whereas in this study it showed that it was a positive in definite 95% positive in definite MS cases and in 85% positivity in clinically isolated syndrome. So final diagnosis question. So initially we have kept it as a demyelinating disorder because of the periventricular lesions, left optic neuritis, and after going through the literature where it was seen the instances of APLA positivity and ANA positivity in the multiple sclerosis. And then also we have kept a differential diagnosis as undifferentiated connective tissue disorders and probable multiple sclerosis. So the question is whether the patient who has presented now, who had ANA positivity, APLA positivity, and cells with CSF demonstrating of more than 50 cells, whether really it is an MS and moreover she had a single attack, or whether it is another related condition, or whether it is a multiple sclerosis mimic.
You can continue, I think. Last slide. Next slide you can.
Yes. So take home message. So while evaluating patients with demyelinating lesions of CNS, MS and MS mimics has to be considered, choosing an immunomodulatory drug is important. It is better to choose a drug which is effective against both multiple sclerosis and its mimics. Patients need to be followed up closely for any new symptoms or any other organ involvement.
Okay.
End of the case, yeah.
Yeah, Dr. Rohit, it was a very good case and you presented very well. A lot of take-home messages are there in the case. How much time do we have, Dr. Raghu, for the discussion of the case?
We have more than 5 minutes left, sir.
Okay. I invite opinions from the panel. We have Dr. Rajesh, Dr. Netra, and Dr. Savit on radiological findings.
Let's hear Savit's opinion on the MRIs. What does he think of, whether it is DAT or is it satisfying both?
Sir, the MR lesions, the morphology and the distribution was typical for a demyelination. There were juxtacortical lesions, there were oval-shaped periventricular lesions. The location of the spinal cord lesion was also very typical for a primary demyelination, that multiple sclerosis. The only point was that all of them were enhancing. That is a little unusual for multiple sclerosis. They should have lesions of different age. So there should have been some non-enhancing and some enhancing lesions. The only point against multiple sclerosis in this case was the enhancement of all the lesions. Otherwise, the morphology of the lesion, distribution of the lesion goes very well with multiple sclerosis.
Yeah, so the VEP was also abnormal bilaterally, right? So the optic nerves were not enhancing.
No, sir. Optic nerves are not enhancing, sir.
Yeah, so I think there is dissemination. Were there some lesions which were not enhancing?
Actually, there were few lesions, but they're not very specific of MS, like what you call as a UBOs. So she was 30-year-old, had diabetes, some history of migraine and all was there. So those are all not enhancing. But majority of the lesion which could clinically have the presentations were showing enhancement is optic nerve was not very suggestive.
But VEP was abnormal, right?
VEP was definitely abnormal, left also, but right also mildly prolonged was there.
Yeah, see, the absence of OCB here could mean that the primary mechanism of demyelination is T cell driven, and probably there's no intrathecal synthesis. Of course, CSF OCB correlates very well with MS than any other infective etiologies or any other kind of demyelinating disorders. But this is certainly not a NMO or more kind of demyelination disorders. It's MS versus its differential. Now this APLA and other vasculitic parameters, often turn out to be positive in many patients with MS, and particularly if the lesions are a little bit aggressive, a lot of enhancing lesions. I found many patients have these things positive. Ultimately, these patients evolve into MS. So probably it just means that there's a heightened immune reactivity in the body where it's firing at multiple antibodies. So I would still feel that this might evolve into MS, down the line. Sometimes we have to wait for time to watch, what is happening. It may not be possible to make a final diagnosis at one given presentation. So, but probably what you did right was to treat her with rituximab, which might work for all kinds of IDDs. Yeah.
The problem here, Dr. Rajesh, is the dissemination in space is fulfilled, but time we don't have any evidence at the moment.
Yes.
One of the things is CSF oligoclonal bands that can be taken as evidence of dissemination in time, but here that also is negative and
Not
MRI
there.
also is. So that way it is not fulfilling the criteria at this stage. That's what I think.
Yeah. Yeah.
Netra, you want to comment on that?
Dr. Rohit, it was a very nice presentation, and the way you discussed about the differentials, everything. So what I would tell is, whenever a patient comes with the first episode of demyelinating episode, as you have emphasized, we should work up for all the secondary causes. Just seeing the MRI and telling that there is 4 areas which are involved, just like what is characterized in the McDonald criteria, it won't be sufficient. Rule out all the other secondary immunomodulatory causes and only then make a diagnosis of MS. But in the first episode, when the patient comes to you with this type of MRI, there is no DIT as it has been emphasized, but definitely enhancing lesions are there. So among all the differentials, what we would consider is MOG also would be a cause, but if it was in a child, that time it can come like this. But most of the other lesions are almost like MS. Dr. Iyer specified, over the time we may come to know whether it is MS or non-MS. At this point of time, yes, rituximab was a correct choice of medication which was given to this patient. If the patient was not affordable, I think in the choices what you gave, you did not give us rituximab, so we did not click on that. So azathioprine is the next best choice, so which has been clicked by many of them. Interferon, definitely not at this point of time, because it is not fulfilling the criteria. That's what I feel.
Another odd thing here is in MS, we want CSF specific inflammation, not systemic inflammation. Here we have got systemic inflammatory markers, but not CSF. That also is another odd point in this case. Do you agree with that?
But sir, what happens is when we see over the course of time, they may come like this with multiple other antibodies being positive. But over the next few relapses, they may evolve into MS or they may just remain as a secondary demyelinating disorder. That only time will tell. So at this point of time, yes, there are few odd features, but it is correct. We treat her with steroids and rituximab and have a periodic evaluation and see how to go about. So the ideal would be before the next dose of rituximab, we work her up and then decide how to go about.
Yeah. Okay.
That is what is planned now. The only thing is the CSF cell count was little in the beginning.
Yes.
I was not very sure it was because we have in MS we have not seen
60 cells is high. 60 cells is high. That's what he pointed out, that there were so many odd points for the MS that that could be outliers. If you take MS, if this patient evolves into MS, this would be an outlier. That is true.
So that's what. So she's now 10 months into the illness. So we had to decide on further. Another issue was she had infertility, which was helping her with telling us, is it also there is a, whether it is an MS associated infertility or any other connective tissue disorders are there. So our immunologist had gone through, he was also not very suggestive of any other, he couldn't place it as a proper connective tissue disorder. So that's what, still the diagnosis is open and being followed. I think in day-to-day practice, it will be like this.
Have you repeated these APLA tests and all? Now you are having...
Here APLA was IgM was positive, so but beta 2 glycoprotein was negative. So they want more IgG being positive. After 12 weeks we did it. It has come as negative now. So IgG is more in this patient. It was IgM. So but beta 2 glycoprotein was negative.
Okay. So if there are no more comments, I think we can sum up the Dr. Rohit. Is that on?
Yeah.
Yes.
Yeah. It was a good presentation, a lot of take-home points. The diagnosis may not be evident in the first presentation itself, so you have to keep all the diagnosis open and work up appropriately. That is the take-home message. And until you exclude the other causes, you cannot conclude that it is MS. Just dissemination in space and time alone is not enough. If you see the McDonald's criteria, the important thing is exclude all the conditions which can come with dissemination in space and time. So that is an important message in this case. Thank you very much, Dr. Rohit.
Thank you, sir.
So we'll move on to the next presentation. Dr. Rajesh Iyer, who is an eminent neurologist, epileptologist, as introduced by Dr. Raghu. He has been running MS clinic for more than a decade or even longer in Bangalore. He has a vast experience in treating MS patients. Dr. Rajesh, you are there?
Yes, sir. Can you see me and hear me?
Yes. Please share your screen.
Yeah, okay. All right, I think the other panels disappeared from my screen.
That's okay.
All right, okay. You can see and hear me, right? Okay, all right. So thank you,
Your
sir.
screen shared.
Thanks to BNet for organizing this wonderful program. And Rohit, congratulations. You presented a tough case very elegantly. And probably, it might add more value to what I'm going to tell now. So the idea is how to diagnose multiple sclerosis. So let us go through this topic in this particular fashion. We look at the symptoms and signs, look at few differential diagnoses, the diagnostic criteria as we had just discussed, its
sir,
dissemination in space and time.
Screen,
yeah?
You have not shared your screen, sir.
Oh, is it? Just a second. Where is it? Just a second. Okay, just a second. All right, I thought I shared. Okay.
Maybe ISG, you can go out and again share.
Wait. It should be there. Okay. Okay. It's not showing my screen actually. When I try to share, it's showing your screen.
Log off and log in, sir.
No, sir, you'll have to click on share screen.
Share screen on green.
Yeah, correct.
After
so,
that,
okay, see what I have done is there's a screen blue button, And Hallmark is sharing your screen?
No, sir.
Yeah, I think so, because that's what is seen on my screen.
No, sir, it's not.
Yeah, correct. That's what it's showing. See, I'm okay. Start video. Okay.
Sir, can you see a green color button, sir? Can you see a green
Yeah,
button?
I'm seeing the green button, and
just click on that.
Okay, all right. So it has to go to application window. All right. Now is it okay?
Yes, sir. Perfect. Now yes.
Okay, all right. So we'll go through this in this particular fashion: symptoms and signs. We look at differential diagnosis, the criteria. We'll try to distinguish from other IDDs, the inflammatory demyelinating disorders. We'll look at how to diagnose a relapse. That's also important, and see some of the subtypes of MS and see where a given patient fits in. So, what is multiple sclerosis? This topic is going to be very basic. It's inflammatory demyelinating disorder of central nervous system, and it is characterized by multiple lesions, or called as plaques, which consist of focal demyelination, inflammation, gliosis, and various degrees of axonal loss. And clinically, the disease is characterized by recurrent episodes of neurological symptoms with recovery in the initial part of the disease. So that is known as RRMS, or remitting relapsing type of MS. And later there will be persistent and progressive deficits and disability in almost half of these patients, where it is known as secondary progressive MS. And rarely it can have a progressive course from the beginning itself, where it is known as primary progressive MS. It's an immune-mediated inflammatory disease. Primarily, the myelin in the CNS is targeted, the destruction of myelin and axon, and significant physical disability in the form of being bedbound or wheelchair-bound happens in about, I'll say the figure is much more than 30%. And the synacon of MS is that the symptomatic episodes are distributed in time and space, and this is something which people have held on to in coming with a diagnosis for multiple sclerosis. Okay, the immunopathogenesis is actually in the system, not primarily in the central nervous system. There's formation of autoreactive T cells, which migrate into the central nervous system, and they invite more T cells to start the immune process. And we know that there's a strong B cell pathway as well. Previously, the disease was considered T cell dependent disease. Now we know that there is a strong role for B cells and other pathways in the immune system. In some patients, there might be one immunological process which is primarily responsible for the disease activity. And this probably leads to a huge spectrum of disease, like a benign MS to somebody with a classical RRMS type of pattern, and somebody with very aggressive disease. So the type of immune response might be different, which might lead to a slight difference in the clinical spectrum. Now, what are the symptoms of multiple sclerosis? So multiple sclerosis comes with certain classical symptoms, or which are typical so-called hallmark symptoms. The first episode of MS is referred to as clinically isolated syndrome, because previously there was, before the present criteria came into existence, CAS was considered a unique entity. Now that is becoming a little bit hazy. CAS refers to the first or single attack of CNS inflammatory demyelination that is suggestive of MS. It can be focal or multifocal, and typically a patient presents with either optic neuritis, involvement of the optic nerve, the brainstem, or the spinal cord. So these are the classical presentations of MS, but rarely it can also present as cerebral hemispherical syndromes or cerebellar syndromes. But the usual presentation is where the neurons are quite dense, which leads to clinical findings. And when we do MRIs for patients with one of these presentations, you do find other lesions in the brain. Now, is a CAS symptom due to MS? So when somebody comes with the first presentation, how do you recognize that this could be due to MS, and you do the test? So to be termed as CAS, the episode should last for at least 24 hours. It should happen without fever or infection and with no clinical evidence of encephalopathy. And what usually evolves is the deficits develop subacutely over 2 to 4 weeks, and usually resolve completely or partially over 6 to 8 weeks, either spontaneously or with treatment. It is recognized by the classical clinical features, which we'll describe. Then supportive investigations, the MRI, VEP, sometimes CSF analysis. We may not require a CSF in all patients. And it's important to exclude the mimics wherever indicated. And at times, as in the case that was presented, you need a follow-up to come to a final diagnosis. Now, what are some of the clinically isolated syndromes? The first one is optic neuritis. The typical optic neuritis of MS is unilateral, and it's a retrobulbar neuritis. So typically painful with eye movements, there is pain, and some recovery is usually expected. There are no retinal exudates when you do a fundus examination, and disc hemorrhages are infrequent. And when you examine, there'll be a sectoral or diffuse pallor after a few weeks of optic neuritis. And the appearance of disc does not correlate with the amount of inflammation, changes in the visual field, or loss of visual acuity. On examination, one might find an RAPD. So this is one example. Here's a 28-year-old gentleman who presented with acute onset of blurring of vision, progressing quite rapidly to loss of perception of vision on the left side with painful eye movements. He had no other neurological symptoms. And on examination, he had left RAPD, fundus was normal, and vision was quite severely affected. He had only perception of light, no long track signs. So this is his initial MRI, which shows that the left optic nerve is enhancing. And by this time, you already see that there are a lot of white matter lesions. And his VEP showed that it's quite flat. So when somebody presents like this with optic neuritis, you have lesions like this with quite severe visual loss. You think of various differentials for this. With a severe optic neuritis, one probably would think of a ADEM kind of thing or a MOG syndrome. This was quite few years ago when we didn't have all those things. But then subsequently, the MRI evolved more like multiple sclerosis. So this is one of the presentation where at the time of diagnosis itself, you have other lesions in the white matter. This is a 35-year-old lady with progressive visual loss of right eye, followed by left eye over a span of 1 month. There was no pain. And on examination, she had counting fingers at 2 feet and left hemianopia. Now, hemianopia is an unusual finding in MS, and it usually indicates more posterior involvement, particularly the optic chiasm. And that's what you see here. You see this right part of the optic nerve to be edematous and hyperintense, and it is enhancing. There were no brain lesions. Her NMO and MOG were negative. So this is likely to be a NMO spectrum disorder. This is yet another girl with progressive but mild visual impairment of left eye since 2 weeks with pain in the forehead, increasing with eye movements. And you can see that the left optic nerve is a little bit edematous and bright and enhancing. So there is clinical evidence of optic neuritis. All her workup was negative and CSF was not done. MRI brain is normal. Here the diagnosis is just optic neuritis. You don't label it as anything else, and she's only 18 years. So a follow-up will tell us what it is going to evolve into. So the optic neuritis of MS has certain classical features. It develops approximately in 40% of patients with MS at some point of their life, and this may be the first symptom in 20% of patients. And the symptoms they describe would be like transient flashes of light or black squares. And typically the description will be like seeing through a cloud or smoke. And it is often subacute, but can evolve over a span of hours to days in many instances. Generally, the fundus may look normal, or it might show hyperemia in some instances. Severe disc edema, hemorrhages, or exudate should be red flags for considering a different lesion. There might be altered color vision, and this might persist for many years after the initial insult. And typically, visual acuity recurs pretty rapidly with treatment, and even without treatment, most patients do get back their vision. But there might be some residual defects in color vision, contrast sensitivity, and all. Another interesting phenomenon that MS patients experience is Uthau's phenomenon. This is exacerbation of symptoms by exercise, hot meal, or bath, where the temperature increases and symptoms get worse. And something called a Pulfrich effect, where the latencies between the eyes are unequal, and this results in a sense of disorientation in moving traffic. The next set of presentation is the spinal cord syndrome, and there's something called a MS hug. So one of the symptoms of myelitis is band-like sensation, which most patients refer to as MS hug. And any of the typical spinal symptoms can occur. Typically, it's a partial spinal cord involvement. About half or less than that will be involved. Sensory symptoms are more common than motor. Bladder involvement can occur. Lermit sign, that is when you flex your neck or move the neck, you get a shock-like sensation which goes down the spine. That is another symptom quite typical of MS, and sometimes it can present with acute dystonias. So this is a 31-year-old lady with history of paresthesias below hips for 10 days with clumsiness of walking. No bladder symptoms, no past history. On examination, she had mild proximal lower limb weakness, sensory level at level of umbilicus, and mild tandem ataxia. And this is what the MRI shows. There is a hyperintense lesion in the lower part of dorsal cord, which is enhancing with contrast. And when you look at the brain, there are lesions in the corpus callosum, few radially situated, and in the white matter as well. So there is a clinical symptom corresponding to an MRI finding and even silent lesions. So as we were describing about the diagnosis, there is dissemination in time and space, which fits into a diagnosis of MS. So in the spinal cord or the brainstem involvement, there is yet another. I will not go into too much of details into that. In the brainstem, maybe I can show you another case and then come back to this. Yeah. So this is a 33-year-old man who presented with paresthesias of both legs for 2 months and progressive paraparesis since 2 weeks and urgency of urination. And on examination, he had weakness of both lower limbs without a definite sensory level. But then this is what the MRI shows, a long segment involvement in the dorsal cord. And the brain image is normal. And his CSF, NMO, MOG was negative, and the serum was negative and CSF was normal. The cause of LETM is not certain in this case. LETM stands for longitudinally elongated transverse myelitis. Probably it is a NMO spectrum disorder. I think we see more NMO spectrum disorder than the seropositive NMOs here. And so this is one example of a non-MS kind of inflammatory demyelinating disorder. Coming to the brainstem or this, intracranial CAS syndromes. So classical syndromes are the oculomotor syndromes, internuclear ophthalmoplegia. Patients can have hemisensory syndromes, rarely hemiparesis. Trigeminal neuralgia can be a presentation of MS. This is one case, a 36-year-old lady who presented with difficulty in swallowing, generalized weakness and imbalance while walking of 2 days duration, quite acute. And she had bulbar dysfunction. On examination, bilateral palatal palsy, right hemiparesis, weakness of tongue, reduced sensations in right side of body. In this presentation, one might probably think of a stroke. But this is what the MRI shows. There are demyelinating lesions in the brainstem, medial medulla. And here the patient already has black holes, suggesting that there's something which has happened quite some time earlier. So this again fits into your diagnosis of MS based on the dissemination in time and space. So the brain involvement in IDDs can be distinguished based on where the lesions are. Savit will be telling about this, so I'll not go into the details. Sometimes certain rare symptoms do present in MS, aphasia or dysphasia. I've seen at least a couple of patients whose only presentation was dysphasia, and then MRI showed typical lesions of MS. Seizures could be a rare presentation, dystonia, facial myokymia, but generally imaging will help in these situations. Now coming to the diagnosis of MS, these are the presentations of multiple sclerosis, and based on these symptoms, of course, you can come to a conclusion that, okay, there is something happening in the central nervous system, and probably it could be of demyelinating disease based on the history and evolution. And for diagnosis, you should have objective clinical evidence of CNS involvement. Objective clinical evidence means you should have a clinical finding of neurological deficit, either optic neuritis or myelitis or hemispherical dysfunction or brainstem dysfunction, along with paraclinical evidence in the form of either a VEP being abnormal or the MRI showing abnormalities. And then comes the CSF. And if there is evidence of dissemination in time and space, documented by clinical, paraclinical, or lab criteria, that should be sufficient for a consideration of MS diagnosis. But it's important to explore other conditions that could better explain the clinical and paraclinical findings. This may not be required in all cases. When you see black holes and things like that, when somebody presents, you may not require all these things. But when somebody comes for the first time, if your dissemination in time is not very clear, then this becomes very, very relevant. Now, what is dissemination in space and dissemination in time? Rohit was mentioning about this article by Thompson. This is the last revision for the McDonald's criteria came up in 2001. McDonald was a New Zealand neurologist. Subsequently, there have been revisions in 2005, 10, 15, and this is the latest one which happened in 2017. So for dissemination in space, it should be that there are more than one T2 hyperintense lesions that are characteristic of MS, in the sense that they should involve at least 4 regions of the central nervous system, either periventricular, cortical, juxtacortical, infratemporal regions, and spinal cord. Spinal cord was added quite later. And dissemination in time should be demonstrated by simultaneous presence of enhancing and non-enhancing lesions. So this is a very valuable criteria, so that when you find enhancing lesion with evidence of previous insults, that would be sufficient for a diagnosis in many cases. Or there should be new lesions in follow-up scans. And if this criteria is not fitting in, then a CSF criteria can be brought in. And that is what the new criteria did. It brought in CSF OCBs as equivalent to dissemination in time. Now, looking at the CSF in multiple sclerosis, we'll not go into the details too much, but oligoclonal bands is something which is present in almost 90 to 95% of patients with MS. If there are questions, we'll take it up later. And there's increased CSF IgG synthesis. So intrathecal immunoglobulin synthesis is another indirect evidence of immune reaction happening in the nervous system. Then there's something known as MRZ reaction, which is the presence of antibodies against mumps, rubella, and herpes zoster antibodies. Presence of any 2 of these correlates very well with the diagnosis of MS. So for the revised McDonald criteria for dissemination in time and space, I think Rohit has described this already, but basically you're looking at evidence for at least 2 events scattered over time and space, either on clinical or on radiological evidence, or if the dissemination in time is not available, you see the CSF findings for oligoclonal bands. Once OCBs appear in a patient, it stays permanently there. And why this is equivalent to dissemination in time is because in a large population of patients, the presence of OCBs correlated very highly in patients who ultimately evolved into MS. So that was why it was taken as an equivalent to the presence of DAT. And for progressive MS, there should be the progression of at least 1 year, independent of clinical relapse, plus 1 or more hyperintense lesions characteristic of MS in the typical regions mentioned. And of course, if CSF OCB is there or 2 spinal cord lesions are there, that should be additional supportive criteria. So this is an example of a 45-year-old man who had neurological symptoms since 2012, dragging of feet after jogging, which worsened over the next few years, then bladder symptoms, and then gait imbalance, fatigue in the last 1 year or so. On examination, he had increased tone in both lower limbs with normal sensations, little bit of spasticity and difficulty to walk. That was his primary issues. And this is what his previous MRI showed. There are lesions in the spinal cord on the right side, very typical of MS. His VEP was showing bilaterally prolonged P100 latencies. MOG NMO was negative. CSF was negative in his case. And a follow-up MRI done last year does show involvement of few lesions in the brain. So this is one of the presentations of primary progressive MS, which is very rare. It's not a common thing to have PPMS. SPMS is more common than PPMS. The differentials are quite important to consider when we look at somebody who presents with CNS IDD. Infectious diseases like syphilis and HIV, inflammatory conditions like sarcoidosis, other autoimmune diseases, the other inflammatory demyelinating disorders like NMO, MOG, ADEM. At presentation, there are also differentials. B12 deficiency. Rarely copper deficiency can present with myelopathy. Then vasculitis and small vessel ischemic disease in elderly people is a very close differential for MS, and we have gone wrong in many instances. And then, of course, probably Savit will be describing the differentials, so I'm not going to this. But at first presentation, we need to look at other possible IDD conditions to be excluded before we consider MS as a diagnosis. Okay. So what happens once we diagnose CAS? So at that point of time, can you consider this as multiple sclerosis, or are they two different entities at all? So as I said, CAS is the first clinical episode of possible MS. Now what happens after CAS is if so for example, somebody presents with optic neuritis or a spinal cord presentation, if the brain MRI is normal in these patients, there are no silent white matter lesions, then the chance of them developing into MS ultimately is very low. It's only about 20%. But at presentation, if there are other white matter lesions, then the chance of getting into MS is almost 80%. So if there is that's what I showed one case where you have a spinal cord lesion and brain lesions. At that point of time, you don't diagnose them as CAS, although that was the first presentation. It is already MS at that point of time. So if there are brain lesions distributed across time and space, it's already MS. And although it is the first presentation, it is no longer CAS. And the importance of this is that you start early treatment, because a lot of data suggests that if started early, the disabilities can be prevented in many of these patients. In the clinical course, MS behaves in two patterns: the remitting relapsing type, where you get a symptom of CNS demyelination. It improves with or without treatment. Then there might be another episode and then another episode. That goes on. And then there may be a progressive kind of disease where there will be, a steadily progressive disease, primary progressive MS, or there can be an initial aspect of remitting relapsing disease, and then it progresses stepwise. So it's a secondary progressive disease. I'll show you examples of that. Okay. Now, what is a relapse? So this is something which needs to be defined very accurately, because MS patients do develop a lot of symptoms, even if there is an infection, mild upper respiratory tract infection or a UTI, they do develop a lot of symptoms which might be difficult to distinguish from relapse. So relapse is a monophasic clinical episode with patient-reported symptoms and objective findings typical of multiple sclerosis. So we know all the classical symptoms of multiple sclerosis, which reflects either a focal or multifocal inflammatory demyelinating event, and it should last for at least 24 hours, and without or with recovery, either can be there, and in the absence of fever or infection. That is very, very important, absence of fever or any infection. And this can be diagnosed either by clinical. It's important to have proper notes for MS patients so that you know what were their baseline deficits. And sometimes you would need a scan to know whether it's just worsening of their previous deficits or there is a relapse happening. Now, it's also important to know what are the prognostic factors, because this has a lot of bearing in the treatment and the follow-up also of patients. So there are good prognostic factors in MS: age less than 40, females. If there are isolated sensory symptoms like trigeminal neuralgia, optic neuritis, descending tract sensory symptoms, not the motor symptoms, cranial nerve involvement, long interval between relapses, more than 2.5 years, and if there's no disability in 5 years, these are all good prognostic factors. And males, age more than 40, short attack intervals, frequent relapses in the first 2 to 5 years, severe relapses, multifocal relapses, descending tract involvement, sphincter involvement, incomplete recovery after an attack, rapid accrual of disability, all these things and progression from onset indicate poor prognostic factors. Of course, imaging factors are also important: high lesion load, black holes, and persistent enhancement after treatment, infratemporal involvement, early brain atrophy. These all indicate poor imaging, prognostic factors. Now, the importance of knowing all these things is because you need to catch the disease when there is a lot of inflammation. So this is a timeline of MS. As the disease begins, there will be a lot of inflammation and regeneration as well. As duration goes, this comes down, there'll be destruction, and there'll be progression of deficits where somebody enters into a secondary progressive MS. Okay, so the issue here is that we have a very limited clinical window or the opportunity to treat. Now, we know that when somebody gets into a progressive phase of disease, the treatment generally doesn't work. Most of the treatment that is available is for the inflammatory type of MS, where the disease is still remitting and relapsing. And what happens to somebody who presents with CAS? So these are the outcomes. Some still remain in that initial phase of disease. They don't progress at all. About half of them get into the RRMS phase, and half of that get into, or maybe a little bit more than that, get into secondary progressive MS. And this is particularly common in India, where many patients don't get initial treatment. So this is an example of a 46-year-old lady who had remitting relapsing disease for almost, I would say, 25 years. And each time she had taken steroids and got well, each time without any residual deficits. And when I last saw her 2017, she had only sensory symptoms, and on examination, nothing else. Cognition was normal. And her MRI shows all the typical features of MS. So she has had recurrent episodes of remitting relapsing disease without adding too many problems to her. And this is an example of what we call as benign MS. This is one of the subsects of MS where this happens in about 20% of patients. It's a retrospective diagnosis. It's not fair to diagnose somebody with benign MS when they present. But then those people who have all those good prognostic factors that I mentioned would be candidates who might ultimately evolve into benign MS. Okay, this is the other spectrum of multiple sclerosis. This is a 33-year-old lady who had optic neuritis in February 2016, improved with steroids, didn't come back up for treatment. The initial MRI shows that there are already plenty of lesions in the brain. The optic nerve was enhancing. And after 3 or 4 months, she developed right hemiparesis, ataxia, dysarthria, and diplopia. In a matter of 3-4 months, she has developed so many lesions in her brain. And this time she was treated with methylprednisolone, no benefit, and she required plasmapheresis. And then she was started on natalizumab, and subsequently she has remained well. So this is a case of aggressive onset multiple sclerosis, where there are a lot of lesions which happen very quickly, and then these are the patients who are prone to develop a lot of disabilities very quickly. The another aspect of the diagnosis of MS is to recognize something called secondary progressive MS during the course of disease. Let me explain this through this case. A 34-year-old lady with optic neuritis in 2009. She was probably treated with steroids at that point of time, and then monitored. 2012, she developed incoordination, but she was planning pregnancy, so declined DMDs. 2014, post-delivery asymptomatic, started on interferons. This is her MRI in 2012. Already you see that a lot of lesions, black holes, the Dawson's fingers, infratentorial lesions. So all the bad prognostic signs are already there. And 2016, there was mild worsening of gait with enhancing pontine lesions. So she was escalated to natalizumab in 2016. And then, she was doing okay for some time. In 2018, she developed clumsiness and, difficulty to walk. The MRI didn't show any new lesions, but probably a little bit of brain atrophy. And then gradually, this is what happened to her. She found it difficult to walk. I'm sorry, this is okay. So at this point of time, she has developed a lot of spasticity and ataxia. So here she has gone into secondary progressive MS. Secondary progressive MS often manifests very insidiously. And then the only manifestation might be difficulty to walk or stiffness in the legs. It's very important to recognize this because the treatment that you're going to give for RRMS is not going to work here. And there are very few options like rituximab or azathioprine, but the outcomes of treating SPMS is not very rewarding. This is another spectrum of multiple sclerosis. This is a 47-year-old lady who had only giddiness as her symptom. And since a family member had brain tumor, she got an MRI done. And this is what her first MRI shows. There is, typical white matter changes and black hole. No enhancing lesions, and this is referred to as radiologically isolated syndrome. The importance of this is that 1/3 of them ultimately develop MS. So this is a follow-up MRI, shows that the lesions are probably remyelinating, but more or less, she has no deficits. It's just that the MRI does show changes. So this is a syndrome of radiologically isolated syndrome in multiple sclerosis. This might also be considered as a preclinical phase of MS. So people might have RIS for some time and then develop the first episode where you can call it as CAS, and then go on to develop the classical RRMS kind of multiple sclerosis. So there are a lot of other symptoms with people with MS experience. There can be cognitive dysfunction. Fatigue is a very common symptom. Pain, various kind of tract pain can be there, and then various kind of musculoskeletal pain, various kind of bladder symptoms primarily related to bladder dysfunction. Spasticity is another problem which many patients with progressive MS or spinal cord involvement develop. So coming to this question, this case is quite similar to what Rohit presented. This is a 21-year-old lady with left eye diminished vision for 3 days. And on examination, she had reduced visual acuity and no other deficits. So if you look at the MRI, what is your diagnosis at this point of time? For want of time, I'm not going to ask you to answer. But if you look at the MRI, there are enhancing lesions, almost ring enhancing lesion here. And there are also non-enhancing lesions in other parts of the brain in white matter, extracortical, yes, and periventricle as well. And but there are few corpus callosum lesions here, like early Dawson's fingers. So there is so the question is it multiple sclerosis and should we start treatment, or it's not MS, it's something else because the symptoms are there for only three months, or should we wait for more clinical features to evolve, to wait for dissemination time as well, or check the CS of OCB. So here, since it was only 3 days, and we thought we'll do the CS of OCB, which turned out to be positive, and then that helped to confirm the diagnosis of MS in her case. So there was a very simple case, but this was to highlight that CSF may be relevant in some cases of MS. So I'll summarize through few algorithms. Okay, so when somebody presents with optic neuritis, one has to see whether it's typical for MS or atypical for MS. I have mentioned many of these points. And if it is, whatever be the cause, do the MRI and see whether it is, there are other lesions which might indicate that, okay, there is a high risk of developing into MS. You might even label them as MS if, there are lesions disseminating in time and space. And if it is atypical, look at other various conditions. Of relevance here will be to exclude MOG and NMO. If there's isolated brainstem syndrome, look for the typical MS features of INO, 6-no palsy and all. And atypical, look at the vascular risk factors, Behçet's disease, vasculitis, those kind of conditions, and other inflammatory disorders which present with isolated brainstem syndromes. And if there's a spinal cord syndrome, the differential is again too many. It becomes quite difficult to, even with a good MRI, it becomes difficult to have a final diagnosis in many instances. But if there are coexistent brain abnormalities, the diagnosis becomes pretty easy. But if there's a very focal, less than 3-segment involvement, focal cord involvement rather than pan cord involvement, you might probably consider MS ahead of any of the other differentials. Okay, this I will skip. It is already described. Okay, so to conclude, what I will say is that MS is actually a spectrum of disease. So preclinically it has something called a radiological isolated syndrome. And once it presents, it's known as a clinically isolated syndrome. And then once somebody has CAS, it can evolve into an RRMS, or it can evolve into a primary progressive MS. RRMS can have various parameters, like it can be a benign kind of MS, and then you can have somebody with various kinds of activities, mild to very severe activity, and then it can progress to secondary progressive MS. And there is something called a myelocortical MS, where patients typically have spinal cord disease, and when autopsy is done, you do find cortical pathologies in these patients. So this is a summary of the diagnosis of multiple sclerosis. Thank you for your listening.
Thank you, Dr. Rajesh. It was a very exhaustive talk on all the basics of clinical diagnosis. As the questions will come up, we'll discuss the question that was raised in the previous topic. Dr. Ratnavalli has raised one question. I think that is relevant to this talk also. Oligoclonal bands, when we do the test, in some labs it comes negative, in some labs it is always positive. How do you explain this discrepancy in OCB results? Does lab methodology make a difference?
Yes, the best way to do OCB is by this isoelectric focusing. I think NIMANS does that. but I'm not sure what is the technique, because not a very common test. MS itself is quite rare, so the test is not very commonly done. And then probably this is the reason why we are not getting accurate results, particularly from many of the private labs. So it's always better to send to a center which does it more often. And I personally prefer to send it to NIMAN so that we get good results.
Yeah, I think even in the criteria, it is clearly mentioned that you had to check OCB by only isoelectric focusing. I think that methodology could make some difference. And I also get an impression from your talk that OCB is almost diagnostic of MS. Is it? That's how do you look at it, or
No,
it's
it's
just
not,
a supportive tool? Or
yeah, so OCB can, so you don't do lumbar puncture and OCB analysis in all patients with MS. So it can be positive in other various conditions, a lot of differentials for that, including, I quickly took up that slide, but then it can happen with various kind of infections and in many patients with NMO and MOG also. So it's not pathognomonic of MS. It only adds to another criteria when you have difficulty in classifying dissemination over time. That is where you use the OCB, and never for a direct diagnosis of MS. The presence of OCB doesn't distinguish MS from other disorders.
yeah, good. I don't see any other question at the moment on your talk. Do you see familial MS, and what is the recent update on genetics of multiple sclerosis?
Yeah, so there is a genetic correlation for increased incidence in families. Twin studies have shown a small increase, but probably there is an environmental common factor there as well. So presently what we understand is the disease is primarily environmental in patients who are having a genetic susceptibility to develop MS and other autoimmune disorders. So there is no definite gene associated with multiple sclerosis.
So if a sibling of a MS patient asks, what is my chance of getting MS? Can we give a figure to them, to her?
I'm not,
is there any?
I don't have an immediate answer, but at least in twins, we know that there might be a small increase.
Okay. I remember 10% is some figure in some literature. I cannot say what it is.
Okay.
So, yeah.
Another question is that CSF MRZ reactions, so measles rubella, how specific and is it available here? So can we do that?
We have not done that. We have not tried that also. So presently, we are quite happy with our diagnosis of MS based on clinical MRI and sometimes OCB. Very often, we are not in a hurry. We wait for time and follow up to tell us what the disease is. But then this seems to be a good point. The antibodies against these three viruses doesn't happen in NMO and MOG disease. So in almost 98% of patients with NMO and MOG, it was negative. So to distinguish between MS and other IDDs, this becomes so sometimes it becomes very difficult to distinguish MS and these two conditions. Then this might prove a little bit of, this might have some utility in that situation. But otherwise, in routine clinical practice, it may not be that relevant.
Okay. Another question is late onset multiple sclerosis. What are the clinical features? Are they different from the typical MS? Late onset.
So when we look at MS in general, so those who present in their 20s, the disease tends to evolve a little bit slowly than those who have disease after 35 or 40 years of age. And if you look at the time to disability or the amount of disability they ultimately develop, what patients who develop at 40 years, who develop MS at 40 years, become at 45 years, is similar to what patients develop at 20 years and when they reach 45 years. So the EDSS at 45 years might be same for somebody who developed MS in 20 years and somebody who developed MS at 40 years. That means at later ages, the disease is going to be a little bit worse. But symptom-wise, it has to present in the same fashion. It's inflammation, demyelination involving the central nervous system. But beyond 60 years, we have patients who have had MS beyond that. The disease, what I have seen, few patients, they seem to have a little bit milder disease than what we see in the 40s. This is my personal experience. But there's not much of data on elderly MS, as we have more information on pediatric MS than on elderly MS. But when we were discussing with Friedman and all, he was saying that it's not very unusual. And his experience is that people above 65, 70 years do present with MS, with optic neuritis, and other classical symptoms of MS like other patients.
Yeah, thank you. And you have already mentioned that there can be a progression of the disease. Clinically, they may look quite okay, but underlying disease can progress. So, how do you monitor patients on disease-modifying drugs like
Yeah,
interferons or glatiramer?
correct. So the target of our therapy is NEDA, no evidence of disease activity. So we are looking at various fields. Previously, it was no clinical relapse, no radiological changes, and no progression of disability. We are satisfied with those three. So we need to look for these three criteria during follow-up. Plus, in addition, we have absence of radiological atrophy as well as cognitive dysfunction. These two we are not monitoring very closely. But then in a patient with RRMS, these three criteria should be more than enough. But then when somebody has MS for quite some time, say 5 years or 10 years, and the MRI, serial MRIs doesn't show any progression, that is when, and when they complain of symptoms like extreme fatigue, difficulty to walk, those are these indications where somebody is losing their neurological reserve and getting a progressive kind of disease. So the only way to monitor this, MRI is not going to give you any information, is the way to monitor this is to see how they do in their day-to-day activities. The easiest thing that I tell patients would be to fix 2 points and measure the time taken to walk across these 2 points on a periodic basis. And now all mobile devices come with a timer. So see the time, and if there's a dip in that, then that indicates that there's some progression. So this is one way of monitoring patients with a little bit advanced disease, more of when they have more lesions in their brain. And if they are on DMT and these things evolve, that means that they're getting into a progressive phase of disease, and then the routine DMDs may not act. We have to think of changing the DMT to something else.
Okay, I think last question is IgG index, is it superior to the OCB bands?
No, OCB is superior to IgG index. With the case that Rohit presented, probably it is worth doing the IgG index. Again, it's non-specific. So any CNS inflammation infection is going to increase the IgG level. If it is more than 0.7, that indicates that there is intrathecal synthesis of immunoglobulins. OCB is also IgG only. So it's not going to add more value than what OCB is going to add.
Okay. Thank you, Dr. Rajesh. It was a wonderful, both the presentation and the discussion. Thank you very much.
Thank you, sir.
Yeah. Now I invite Dr. Savit Kumar, neuroradiologist, to present his topic, that is differentiating MS mimics from true MS. Dr. Savit.
Thank you, sir. I thank BNET for giving me this opportunity. So can you see my slide?
Yes, yes.
So after good presentations, case presentation by Rohit and Dr. Rajesh on the diagnosis of MS, so I will discuss on the differentiation, neuroimaging differentiation of multiple sclerosis from its mimics. Now, diagnosis of multiple sclerosis is usually straightforward in a patient who presents with typical clinical history. So when the symptoms are not non-specific or atypical, then ancillary tests have a dominant role. So MR is commonly performed investigation to support the clinical diagnosis. So the role of MR is in confirming the disease, assessing the disease burden, follow-up, and to rule out alternative neurological diseases. So the diagnosis of the disease is based on the revised 2017 McDonald's criteria, which also has which has also described the dissemination in space and time for MR imaging. Now, these criteria have a focus on the white matter lesion burden and dissemination space and time. So these criteria alone cannot confirm a diagnosis of MS or rule out a diagnosis. So there are a variety of disorders which presents with objective evidence of a symptom typical of MS and demonstrate clinical or radiological dissemination space and time. So the knowledge of imaging pattern and identification of the red flag imaging findings atypical of for MS will be helpful in making an accurate diagnosis. Now, this is a poll question. Which of these imaging findings is typical for a brain lesion and multiple sclerosis? So all these images are flare images. Okay, 52% of them have told as case 1. Now let us see each case. Okay, the case 1 is a typical imaging feature for multiple sclerosis. Case 2 is the imaging feature which is seen in a small vessel disease. Case 3 is a UBO and migraine, and case 4 is a NMO spectrum disorder. Now let us see each case. Now, typical brain lesion in multiple sclerosis will have both acute and chronic lesions, that is, the lesions at different age. The lesions will be distributed in the periventricular region. The typical periventricular lesion will be ovoid in shape, larger than 3 millimeter in its longest dimension. The lesion will be abutting the ependymal margin of the ventricle. They will be related perpendicular to the lateral ventricular wall. And the juxtacortical lesion will abut the cortex, and also the patients with multiple sclerosis can also have cortical lesions, which will be best depicted by double inversion recovery sequence. Now, these periventricular lesions will give an appearance of a Dawson's finger, and the infratentorial lesions are distributed in the periphery of the brainstem. Like this is an illustration which shows lesions which is involving the cerebellar peduncles and the periphery of the pons, and also have a predilection to the region of the exit zone of the trigeminal nerve. Now, this is a typical Dawson finger where we see ovoid lesions abutting the lateral ventricular ependymal margin and then oriented perpendicular to the ventricular wall. And these lesions are along the venules in the periventricular region, giving a Dawson finger-like appearance. Ependymal dot sign has been described as an early MR imaging feature of multiple sclerosis, which has a very high sensitivity. Now, this is typically seen along the inferior margin of the corpus callosum as hyperintense dots, followed by a normal ependymal signal intensity, giving a dot and a dash-like appearance.
Can I interrupt, Dr. Sabit?
Sir?
There is a background noise. I don't know from whose audio. I request everyone else to mute their mics. Yeah. Please proceed, Dr. Sabit.
So ependymal dot dash sign is one of the early signs which will help us in making a diagnosis of multiple sclerosis with a very high sensitivity. The other sign which has been described in multiple sclerosis is a central vein sign. Now, this is best depicted in a susceptibility weighted imaging where the venule within the lesion is seen as a hypointense linear band, which again has a very high specificity for diagnosis of multiple sclerosis compared to similar appearing white matter lesions. The other sign which has been described is a paramagnetic rim sign. This is again seen on a susceptibility weighted image, defined as increased susceptibility along the margins of the lesion. So this is a lesion which shows a black rim around the margin of the lesion. This is due to iron laden macrophages within the lesion margin and represents chronic active demyelination within the edge of the lesion. And this also has been described to be more specific for diagnosis or in multiple sclerosis compared to its mimics. Now, the enhancement pattern in multiple sclerosis can be a ring. It may show a ring enhancing pattern. It may show a punctate or a nodular enhancement or a patchy enhancement. Now, coming to the first differential, which is a small vessel disease. Now, this is seen in an elderly with vascular risk factors like diabetes and hypertension. The imaging appearance, the periventricular lesions in it may vary from very initial stages showing a pencil thin lining of the ventricular margin to hyperintense cap along the frontal horn and occipital horns of the lateral ventricle to a thick band. Now, this thick band represents ependymal loss or subependymal gliosis. They may be associated lacunar infarcts. Microbleeds may be associated with it. They may show a presence of cortical or subcortical infarcts. Prominent Virchow-Robin space will be seen in these conditions, which predominantly seen in the region of the basal ganglia. unlike the juxtacortical lesions which involve the U fibers in multiple sclerosis, the subcortical lesions in small vessel disease spare the U fibers. These lesions don't enhance. There'll be rarely corpus callosal involvement, and atherosclerotic changes may be seen in intracranial vessels.
Dr. Savit, sorry. Can you use your earphones if possible?
Oh, yeah, yes, sir. So now the noise is lesser, sir?
Yes, much better. Thank you.
Yeah.
Okay, coming to the next differential, that is uveosine and migraine. They are more commoner in migraineurs with aura. They are seen as spunctate or small non-confluent deep white matter hyperintensities. These patients have a higher prevalence for silent brain infarcts, particularly in the deep gray matter and cerebellum. These white matter lesions generally stay stable over time. There's no corpus callosal involvement. There is no cortical or spinal lesions. There is no central vein sign in these conditions. The next differential or the next condition which can mimic clinical symptoms of multiple sclerosis is NMO spectrum disorder. This is also an autoimmune. It's also a primary demyelinating disorder. Most of these lesions are located in the region of the brain which has high aquaporin expression, that is along the ependymal margins, that is periependymal area, the thalamus, hypothalamus, posterior pituitary, the pineal gland, and the brain stem. And also the area posterior behind the brain stem. So these lesions typically show a cloud-like or poorly marginated enhancement or a pencil-thin-like ependymal enhancement along the ventricular margins. The corpus callosal lesions are predominantly distributed along the inferior aspect, that is the ventricular aspect of the corpus callosum abutting the ependymal margin. They also show radial or spindle-shaped white matter lesions, which is seen involving the corticospinal tract. Rarely meningeal enhancement can be seen. Cortical lesions, unlike multiple sclerosis, not seen in this case in these conditions. They have a lower degree of brain atrophy compared to multiple sclerosis. The next condition is MOG antibody-associated disease. Now, the brain lesions in these conditions are seen in about 50 to 60% of the cases. They're usually non-specific T2 hyperintense cortical or deep white matter lesions. They may present with atypical brainstem lesions like hyperintense lesion involving the pons extending to the middle bilateral middle cerebellar peduncles. They may have an Adam-like pattern or focal encephalitis-like pattern or flames, where you see flare hyperintensity, sulcal flare hyperintensities, or meningeal enhancement, which will be usually unilateral and cortical sulcal flare hyperintensities. The other differential, that is a cadasal, which is a microvasculopathy, which presents with widespread predominant or early involvement of the anterior-temporal pole, involvement of the external capsule, and they are present with microbleeds, bilateral lacunar infarcts, prominent Virchow-Robin space, and they generally spare the corpus callosum or cerebellum. The other differential will be a Susac syndrome, which is a small infarctions involving the cochlear retinal or encephalitic tissue, generally affects the female in the 2nd to 4th decade. They present with triad of acute to subacute encephalopathy, bilateral sensorineural hearing loss, and branch retinal artery occlusion. The typical imaging features, what we see is of the corpus callosum and a string of pearl-like appearance of infarcts involving the region of the internal capsule and centrum semiovale or corona radiata. No central vein sign will be seen in these white matter lesions. ADM. Now, these, unlike multiple sclerosis, have large globoid confluent white matter lesions with fuzzy margins. They tend to involve the deep gray matter. Post-contrast, they show open ring type of enhancement, and generally they are monophasic illness, and the lesions tend to resolve, unlike in multiple sclerosis, which may persist or may evolve into a T1 black hole. This is a case illustration showing a fuzzy lesion involving bilateral thalami and a lesion within the cervical cord, and the supratentorial lesion showing an open ring type of enhancement with the ring open towards the gray matter. Most of these illness precede with the viral infection or a history of recent vaccination. Now coming to the multiple sclerosis variants, they include the tumefactive or pseudotumoral multiple sclerotic lesions, the Marburg's disease, which is a fatal variant of multiple sclerosis, Schilder's disease, or concentric sclerosis. Now here what we see is an alternate ring of hyper and hypointensity, signifying the alternating process of demyelination and myelination which happens, giving this concentric ring-like appearance. This is a case illustration of a tumefactive demyelination showing a hyperintense diffusion restricting margin with open ring type or discontinuous post-contrast enhancement in a 24-year-old female who presented with left-sided hemiparesis. Now, while evaluating a patient with suspected or multiple sclerosis, we need to look into or be aware of certain red flag signs which would suggest an alternative or other diagnosis, like a presence of a meningeal enhancement would suggest a chronic meningitis or a sarcoidosis or a vasculitis. Presence of hemorrhage or microhemorrhages would favor other conditions like cadasal, vasculitis, amyloid angiopathy. Presence of a venous sinus thrombosis, one should look into or evaluate for Behçet's disease, vasculitis, Apla syndrome. Presence of punctiform parenchymal enhancement, one should look for sarcoidosis, vasculitis, lacunar infarcts. Again, think of Susac syndrome or cadasal. Simultaneous enhancement of almost all of the lesions, then one should think of vasculitis, lymphoma, sarcoidosis. Presence of a large infiltrative brainstem lesions, then one should think of a neoplastic process, a glioma or a Behçet's disease, or elevated lactate peak within a white matter lesion. Should consider mitochondrial disease. These are the red flag imaging signs which will help us to think other than multiple sclerosis in a patient on evaluation for multiple sclerosis. Now coming to the second poll question, which of these is a typical pattern of optic nerve involvement in multiple sclerosis? There are three cases, case 1, case 2, and case 3. So this is a T2 fats suppressed coronal image of the orbit. This is a post-contrast T1 and a T2 image of the orbit and the optic chiasma region. So these are post-contrast. This is post-contrast T1 and T2 image of the orbital region. So up to 42% of them have told case 2 is suggestive of a typical multiple sclerosis-like lesion. Now let us see each one of them. Okay, so case 1 is typical of multiple sclerosis. You have a unilateral optic nerve involvement. Case 2, bilateral optic nerve involvement. The optic chiasma is normal. It's MOGAD. Case 3, you have bilateral optic nerve involvement with involvement of optic chiasma. Now let us see each one of them. So the typical pattern of optic nerve involvement in MS, it's unilateral, involves a short segment of the optic nerve and extension to the chiasma is lesser as in compared to that of a anemospectrum disorder. So you have a unilateral optic neuritis with without involving the canalicular and the chiasmatic segment of the optic nerve. In anemospectrum disorder, the typical imaging appearance is bilateral, longitudinal extensive optic nerve involvement affecting more than half of the length of the optic nerve, preferably the posterior optic pathway, including the intracanalicular segment and the optic chiasma or optic tract are involved. So we have the long segment involvement of the optic nerve involving the intraorbital, canalicular, and the optic chiasma, and it's a bilateral involvement. So this is a typical presentation in anemospectrum disorder. Coming to MOGAD, again, they are bilateral, preferentially anti-optic nerve involvement, and also what is seen as a perineural gadolinium enhancement. So what we see is striated enhancement involving the perineural sheath and the adjacent periorbital fat, which is seen in MOGAD. So it's a bilateral optic nerve involvement, predominantly involving the anterior part of the optic nerve and sparing the canalicular segment and the optic chiasma. So this comes to the third poll question. Again, which of these is the typical pattern of spinal cord involvement in multiple sclerosis? All are axial T2 weighted images. Oh, 71% of them have told it is case 1. Okay, so the case 1 is typical of multiple sclerosis, case 2 anemospectrum disorder, case 3 MOGAD, case 4 subacute combined degeneration, and case 5 is an antispinal artery infarct. Now the typical imaging pattern is it's a small longitudinal small segment involvement involving less than shorter than 3 consecutive vertebral segments. It's usually peripheral in location, involving the lateral or the dorsal aspect of the spinal cord, and more predilection to the cervical cord, and they show a patchy or a ring-like enhancement on contrast administration. So the anemospectrum disorder, it's a longitudinal extensive transverse myelitis. That is, the involvement is more than 3 contiguous vertebral bodies. It is a central cord involvement with more than 50% of the cord being involved. More prediction to the cervical, thoracic, or cervicothoracic region, and also what is described as a bright spot on T2 weighted images. So this is a T2 central T2 hyperintensity, which is more hyperintense compared to that of the CSF, and appears hypointense on T1 weighted images. This is because of extensive demyelination or microcavitation which develops within the center of the lesion, and they show heterogeneous or lens-like enhancement. So coming to MOGAD, again, they also show a longitudinal extensive transverse myelitis involving more than 3 consecutive vertebral bodies. The predilection is more common for the conus or a thoracolumbar segment of the spinal cord. And there are a few specific signs which have been described. One is sagittal linear hyperintensity, which is seen surrounded by a cloudy T2 hyperintensity. And also this linear T2 hyperintensity gives a pseudo central canal dilatation like appearance. And this predominant white matter involvement, predominant central gray matter involvement gives a H like appearance on an axial image. They show a fluffy or patchy post-contrast enhancement. So this is again the typical imaging features of a spinal cord lesion in MOGAD. Now coming to the other cases which you saw in the list. So here what we see is a dorsal cord inverted V-like hyperintensity involving the upper involving the cervical cord. So this is a 37-year-old male who presented with imbalance while walking. So this is the classical imaging feature of a subacute combined degeneration, which is either usually due to vitamin B12 deficiency or may also happen due to copper deficiency. Now, so this is the other case illustration. We see hyperintensity is predominantly in the anterior gray matter. There is corresponding diffusion restriction. So this is a sagittal image. There are two skip lesions, one in the upper cervical cord, which is near holocord involvement, and second in the lower cervical cord. The lower cervical cord lesion shows diffusion restriction. So this is the corresponding axial image of the lower cervical cord lesion. So this appearance, called as the owl's eye appearance or cobra eye-like appearance, is a signal involving the anterior gray matter of the spinal cord. Also, what we see in this case is disc bulge at two levels, more prominent at C4, C5 level. So this is the anterior spinal cord infarct. In this patient, we did not find a vascular occlusion. These are the flow arts of the vertebral artery which are still maintained. So there was no evidence of occlusion. There was associated disc protrusion which was seen. So the possible diagnosis fibrocartilaginous embolization leading to anterior spinal artery infarct. So to conclude, the clinical and imaging findings in MS can mimic various other pathologies. So one need to be aware of the typical imaging appearance and recognize the mimicking disorders. So the knowledge of the distribution, location, morphology of the lesion will aid in diagnosis. So identification of the red flag imaging findings will avoid misdiagnosis. Thank you.
Thank you, Dr. Savit. Excellent presentation. You covered all the radiological signs and nicely demonstrated the typical MRIs. And as we wait for the questions, I have one or two things to ask you. If you see the, shall I ask, Dr. Savit?
Yeah, yes, sir. Yes, sir.
Okay. Now, if you see the Magnum's criteria, optic nerves are included as the fifth site in the MRI. But in the McDonald criteria, it is not recognized. Why this discrepancy? Why this discrepancy? Why McDonald's does not accept optic nerve lesions as a dissemination of space?
Yeah, I'm not aware, sir, but the 2017 update has removed the optic nerve involvement from the dissemination space from the criteria. So I don't know. I'm not sure why this discrepancy.
Okay. And another thing is the periventricular lesions. Do you use 1 or 3 as the criteria? 1 lesion or 3 lesions? Can you hear me, Dr. Savit? Hello. Hello.
I can hear you, sir.
Yeah. So periventricular lesions, do you use 1 or 3 as the requirement?
Sir, the McDonald's is saying 1, sir. McDonald's says one of the lesion in any 2 of the 2 of the 4 brain regions, brain and spinal cord. So the McDonald's says 1.
In Magnums, they say you need 3, especially as the age advances, you need at least 3 lesions to be counted.
Yes, sir. The McDonald's being the more recent 2017 revision, and Magnum's is 2069. I'm not definitely aware on why there's a discrepancy between these 2 criteria. But actually, the McDonald's has revised it and has only asked for 1 lesion in any of this, 1 or more than 1 lesion in any of these areas, that is any of the 2 areas.
Okay. The other thing is to monitor the progression of MS. Now they say you can monitor the iron deposition, especially in the thalami and basal ganglia. Is it in the clinical practice now or still in the experiment trial stage?
There is a quantitative susceptibility. Yeah, the quantitative susceptibility mapping sequences are available, but most of these sequences are usually given as a research tool or a trial tool. So most of the publications are as a research. The only problem is it is a very tedious process to quantify the iron within these susceptibility lesions. So most of the institutions which are doing it as a research tool, but it is not there in a regular clinical practice, or it is not at present feasible to do it on a regular basis.
Fine, thank you. That's all from my side. I will ask Dr. Raghu to decide whether to proceed with the next talk.
Last question. So the central vein cannot be seen in 1.5 Tesla. We require a 3 Tesla or
this susceptibility, we need to have SWI sequencer, SWI. So that is one of the best sequence for susceptibility weighted imaging. Most of the literature has described it in 3 Tesla, but susceptibility weighted SWI sequence in a 1.5 Tesla also will be able to pick up the central vein. But the resolution or the ability to pick up by a 3 Tesla will be far better compared to the 1.5 Tesla. That's because of the magnet strength, increase in magnet strength.
Fine.
Okay, so we'll continue.
Thank you. Yeah. Thank you, Dr. Savit. It was very nice and very informative talk. Thank you.
Thank you, sir.
Yeah. Now I invite Dr. Netravati. She's an additional professor of neurology at NIMHANS. She has been running MS clinic in NIMHANS, and quite a large number, more than 500 patients she has already enrolled. She will be talking on the management principles of multiple sclerosis. Dr. Netra.
Thank you, sir. Thanks, BNet, Dr. Raghunandan, Dr. Sharma, for giving me this opportunity. I think it has been really nice that we started with how to identify the clinical features and the diagnosis by Dr. Iyer and the MRI with the mimics by Dr. Savit. And now I'm going to talk about how we identify and the correct patient and the correct drug. So we now know that there are a lot of drugs in the basket of the therapeutic armamentarium in multiple sclerosis. So when a patient comes to us with MS, how do we decide as to which drug will fit to this patient? That is what I'll be talking in the next few minutes. So basically I'm going to discuss based on case-based approach. So coming to this case, this is a young gentleman who came with a right-sided transient paresthesia as noticed 6 months back, which improved with lamotrigine. And then he developed a progressive tremulousness of right hand of 4 months and then speech disturbances. On examination, he had both cerebellar and pyramidal signs. He was diagnosed to have a subacute brainstem syndrome and investigated. So this is his MRI, which shows lesions both in the supratentorial and infratentorial regions, both in the periventricular regions as well as the intratentorial. So rest of the investigations were non-contributory. So what do you think is the diagnosis? At this point, I would like to ask the audience, what is the diagnosis? Can we have the poll, please? Okay, so many of them felt it was 68%, 11% MOG aquaporin, the last was MOG and brainstem syndrome. So I'll just go back to the MRI and the clinical features. So if we take the clinical features, and the criteria which was already discussed. So if we take the McDonald's criteria, it says that there should be at least 2 among the 4 regions. But Magnim's criteria has been proposed recently. One of the questions which Dr. Sharma sir was asking was why there is a discrepancy between the McDonald's criteria and the Magnim's criteria. So the McDonald's criteria forms the basis for our MS diagnosis. The Magnim's criteria came up in 2016, which included few of the more extra, especially the optic nerves. But that has not yet been incorporated into the McDonald's. One of the reasons is if we take the fifth involvement, that is the optic nerve, even the NMO mark sometimes can be misdiagnosed as MS. That is the reason, one of the reason it has not been still incorporated into the McDonald's criteria. So if we take now this criteria and come back to our patient, so we try whether we'll see whether this patient fits into the McDonald's criteria. So if we see patient has the infratentorial region as well as a periventricular, but there is no subcortical nor a spine region. So 2 out of 4 it fits in. So everybody is happy, McDonald's. But what we should remember is not all 2 of the regions is for MS. For example, if you take this, the periventricular is actually going further into the deep gray matter and also involving the thalamus. And now you take the infratentorial, you can see that these are almost like a coalescent involving, encasing the midbrain as well as going down to the pons. So this is not a characteristic location or a lesion of a MS. So I will again reiterate that this is not classical. So it is not just about fitting whether the area is fulfilled. We should also see periventricular, whether it is really perpendicular to the corpus callosum. And if it is present in other areas, whether it is coalescent or whether it is a plaque. Coalescent plaque may be there, but it can't be a diffuse lesion, especially like this, which is there in the midbrain, which is present here. So this was one of the reasons, as well as clinically, he had a progressive disorder for nearly 6 months, especially in the first 3 months. So that is also unusual for a patient of a MS to present with. That is the reason we further evaluated this patient, and this was HLA-B51 positive, and the diagnosis was Behçet's disease. So what I want to reinforce here is not all 4 areas, 2 out of 4 areas can be taken as a diagnosis of MS. We need to see the characteristics of the location of the lesion and be sure whether it is fitting in. And first, your baseline workup whenever a patient comes with a CNS demyelination is not just a clinical and MRI, CSF, and then start treatment. Please do all the workup which is required for a secondary demyelination, especially if they are not fitting into the criteria, and then go ahead with your immunomodulation. I would reiterate, rule out a MS mimic. And MRI is very crucial. Almost all of us are, I think, intelligent enough to distinguish between NMO and multiple sclerosis. But we should remember MOG is one disorder which sometimes can mimic multiple sclerosis. So it is important to have a knowledge as to how to differentiate so that we do not err in the making a diagnosis. So whenever we have a patient of a CNS demyelination, first you have to rule out, exclude other causes and see whether the patient is fitting into the McDonald's criteria. And then fine, now you have made a diagnosis of MS, then see whether there is a bad prognostic factor or a good prognostic factor and assess the level where the patient is. That is the severity of the illness where the patient is. That I will tell with the future diagrams, and then start the medication. Medication should not just be the DMA. We should also see there should be a comprehensive approach. Most of our patients can have multiple other involvement, cognitive, behavioral changes, caregiver burden. So there should be a comprehensive, a team approach between a neurologist, psychiatrist, psychologist, psychosocial worker, rehabilitation, physiotherapy. So all of these should be there whenever you treat a patient of multiple sclerosis. So now if I have to talk on the good and bad prognostic factors, I'll just talk on the bad prognostic factors so that we remember. So the rest is all good. One is the higher age at onset, especially after 35, 40. We do not have actually a cutoff as to this lower than this is good, higher than this is bad. But if it is above 40 and 50 years of age coming with the first episode of demyelinating, then it is a bad prognostic indicator. Male gender and motor onset. What do I mean by motor onset? Many of the patients sometimes can come with just a sensory symptoms, mimicking carpal tunnel syndrome or a joint position sense involvement. So these are not sensory, these are sensory symptoms which are actually good prognostic indicator. Motor would be your disability, pyramidal involvement, brainstem, cerebellar, these are all, and spinal involvement. So these are all bad prognostic factor. And having multiple comorbidities, it could be either a systemic comorbidity or a connective tissue comorbidity. And a high relapse rate, especially if they've had 2 episodes of relapse. One of the way to remember is 2 relapses within 1 year, please see that you decide about which disease modifying agent you're going to give. And a progressive, of course, progressive, all of us know that it is a bad prognostic factor. And coming to the investigation, the positive OCB and a high lesion load on MRI with a brain atrophy. All these are bad prognostic factors. So a patient comes to you, whether it comes to you in the first episode or the 5th episode, but you may be seeing him for the first time. Please go to all this checklist so that you know how to start the medication. If the patient is not on the correct medication, switch over to the correct medication. That's the reason we need to go through these indicators. So now I will go through how to manage patients of multiple sclerosis case-based. So this is the first case. The first one was a mimic. So this is the first case of a 24-year-old gentleman who had been having a first episode, already treated with steroids outside by a neurologist, and they felt that let us wait, you're just having the first episode, let us wait. So that is the time he came to us for a second opinion. So he had a right eye visual dysfunction of 5 days. Visual acuity was 6/24 on the right side with the RAPD, and we diagnosed it as a right optic neuritis. You can see his MRA, very classical. As I told, again, 4 areas, all 4 areas, it is fulfilling the criteria. So he was treated already with methylprednisolone for 5 days. So next, what I should do, whether I should really wait. I'll ask the audience at this time. Can we have the second poll, please? What do you think is the ideal treatment at this point of time? DMAs have to be started immediately. Very good. Most of them have answered correctly. So, so it is true. We should never be waiting. I will tell you why. I think this was already shown by Dr. Iyer. What I want to emphasize is the patient may be coming to you here or here. But what you have to remember is if you see this orange line, which indicates inflammation, so this inflammation is highest in the initial period and then goes down. But the green line, which indicates the axonal loss, it is one thing which is going to have an exponential increase throughout. So there is a point where it comes later when the inflammation is less and axonal loss is more. So this is the time when the patient shifts from the relapsing form to the progressive form. And this is the time when if you do a MRA and patient is having a relapse, you will not find enhancing lesions because there is no inflammation and only axonal loss. So it does not mean patient is not having relapse. It just means we are not got the patient in the golden time period. So it is very important that we do not lose this therapeutic window where we need to give the adequate treatment so that we start the treatment here. Patient may have very minimal or less disability. In fact, before the onset of the disease modifying agents, there are multiple studies where without even giving medications, they've tried to see what happens to the patients over long term. And they have found that 80% of them over 15 years definitely will become bedbound if they are not treated. So it is important to catch this golden period and to start the treatment early for patients of multiple sclerosis. So as I said, so we'll not wait and start disease modifying agent in this patient. So whenever we are going to start disease modifying agent, if we have to ask, initially the thought process was most of the disease modifying agents were classified based on their efficacy as a first line and second line. And the dictum was that you start low and go gradually, not responding, then you go higher. But now we do not follow that. Depending on where the patient is, even though he's come to you in the first episode, if you find that it is at a higher level, then you will start second line treatment also. You may not be starting at the first line treatment. So now coming to the case number 2, where a clinically patient is doing well, but radiologically there are new lesions. So this was a patient who had come to us with the EDSS of 2. He's had just 2 episodes, and DMF was started 2 years back, and he is undergoing annual MRIs. And the end of 2 years, that is after starting the DMAs, when we saw an MRI, you can see here there are some enhancing lesions in at least 2 areas it is there. But clinically patient is asymptomatic. So what should be done? Can we have the poll, please? So what is the ideal treatment we should be done at this time? Patient is asymptomatic, doing well for the last 2 years, but there are only 2 small, tiny enhancing lesions which are found on the MRI. What should be done? Switch to a higher efficacy disease modifying agent. Very true. I think most of you are correct. So the guidelines say that even if the patient is not taking, even if the patient is doing well, but if the MRI shows that there is new lesions or an enhancement, that means the medication what you're giving is just having a partial effect and not a full effect. And it is required for you to switch or a change disease modifying agent, and the switch should happen to a higher level. That is, if the patient is on a first level, you will go to a higher level, second level of disease modifying agent. And one of the scoring which is taken to assess is the Rio score, where they try to take the how many number of T2 lesions are there and enhancing lesions are there. So based on this, you'll be able to know whether they are responders or not, and then decide on the medication. So coming to the third case, where a patient has worsened on disease modifying agent, again, MRI, no activity. So this is a patient whose last episode has, as you see in last 2 years, she's had 3 episodes, and rituximab was started recently in 2020 February. But in July 2020, patient had a fever followed by paraparesis. So a neurologist examined at that time, found definitely paraparesis was there, lower limb weakness was there, no sensory level. So MRI was done, but MRI did not show any new lesions compared to the previous lesion. So that point of time, the neurologist thought whether it was really a true relapse or a psychogenic etiology. So what does the audience feel? Can we have the poll, please? What do you think is the appropriate line of management at this point of time? I think the slides went a little faster, many of them saw, but 35% of them felt it was a true relapse and steroids to be given. So what I would want to emphasize is that there was a fever which was there followed by paraparesis. So we should remember that it's not Huthoff's phenomenon is not just a transient worsening with heat. So what happens is when the patient is in the initial stages of multiple sclerosis, he may find that whenever there is an increased temperature, he may just feel increased fatigue or slightly transient paresthesias, which may just go away. That may be a Huthoff's phenomenon. But with time, what happens is the patient may have a decreased reserve, so that there is a decreased white matter as well as a gray matter. That means this patient must be a high active MS, so that if you saw there were nearly 3 episodes within 1 year, within 2 years. So that itself says that it was a higher. So what happens is whenever they are predisposed to any increased temperature, it is not that they will just have a transient symptom. They can present as a relapse. And during these cases, it is not that you'll give them steroids. Just give even a tepid sponging, that will help them a lot. Tepid sponging, start paracetamol, ask them to drink some cold drinks. That itself will relieve them. In fact, this patient, what happened was, she went to the MRI, got the MRI done. As soon as she came, she drank some cold juice and she became completely better. That was the reason this patient was considered as a psychogenic etiology by the previous neurologist. So it is important for us to diagnose this Huthoff's phenomenon. So now coming to the case number 4, which is a highly aggressive multiple sclerosis. So as I've already told, this is a highly aggressive multiple sclerosis. So this is a recent MRI. So this was the first MRI, the lowermost is the first MRI. You can see here in 2018 November, when she was started on dimethyl fumarate, you had lesions which were there for all 4 regions, and it was quite exhaustive. You can't count the number of lesions, and the patient is taking dimethyl fumarate very regularly. Even then, after 1 year, within 6 months, if you see her EDSS has increased to 4.5, and you can see this is the highermost cuts, which is showing that there is an increased atrophy and almost all the lesions have coalesced. So you have motor disability as well as a radiological worsening, clinical and radiological worsening. So this is an example of a aggressive MS or a highly active multiple sclerosis. So ideally at this time point, the patient is on dimethyl fumarate. I would want to know what would the audience do at this time. Can we have the poll, please? Okay. Some people have said that we should be giving higher monoclonal antibodies, and some have even told about cyclophosphamide. So I would want to discuss about this now. So what we have to do is, if I just go back to this patient MRI, so if you see when she came to us in 2018 with this EDSS and the patient was started on dimethyl fumarate, that time itself we know that it is already a highly active multiple sclerosis. She should not be started on a highly active on dimethyl fumarate, which is a first line agent. That we need to start on a second line agent. What I need to emphasize here is initially this was the way we used to start MS treatment. Even when I started treating MS patients, we started first line, not improving, go to the second line. But now, even if the patient has come to you in the first time itself, you need to flip the pyramid. That is, if you find that they're having a high lesion load as well as a high disability, you will start at a higher level. That is, either you will start at a monoclonal antibody like a natalizumab or a rituximab off-label, though it is there, we still use it in many of the multiple sclerosis patients. And only then, if they're improving, come back. If they're not improving, again, go higher up. That is the way it should be in the method of treatment. Few of them also opted that we should treat with cyclophosphamide. Here, I would want to tell that unlike other CNS demyelinating disorders, cyclophosphamide does not have much of improvement in MS patients. Of course, yes, if you see the therapeutic armamentarium, they say when all the DMAs have exhausted, please use cyclophosphamide or mitoxantrone. That is one of the things which is said. Yes, mitoxantrone does help, but cyclophosphamide has a little bit of some studies it has helped, most of the time it does not help. At least in our patients, we have seen that it does not have much of the effect. So it is an immunosuppressant. Maybe it will help if you are considering plus, that is MS plus any connective tissue involvement is there, but not in a pure multiple sclerosis. So high active MS, we should ideally in her case, we should be starting on a natalizumab like medication where it will be very effective in her case. So this is what I said. Even if the patient has come to you at this point of time, it is important for you to hit it hard. Don't go from here to above, hit it hard here. Control the illness so that you are still in the inflammatory phase, and then maybe when it is controlled after a while, if you want, you can come down, but never start at a lower level in a patient with a highly active MS if you see that the MRI is having a high lesion load. So that is the reason now there is a new classification which is proposed, not yet accepted, that the DMA should be classified into moderate efficacy and higher efficacy. So the moderate efficacy are the ones, especially the orals like fingolimod, dimethyl fumarate. High efficacy are the ones natalizumab, ocrelizumab, and alemtuzumab. Presently, we do not have ocrelizumab, but yes, we can still get from the black market. But otherwise, all of these are available and patients can be started on this, control the illness, and later, if required, we can chart it down. So this is one of the chart we should remember. What I have tried to put is the efficacy. Most of the time, the disease modifying agents, the efficacy we come to know as to how much they are effective on reducing the disability, reducing the MRI activity on T2 lesion load, as well as the enhancement. So they take all of these into criteria and then they give the label that this is low level, this is high level. So for example, if you take the interferons and the glatirimab, especially the glatirimab has just 12 to 15% on the disability and the MRI activity, whereas the dimethyl fumarate and teriflunomide has little bit higher efficacy, especially dimethyl fumarate compared to teriflunomide. It has around 30 to 33% or sometimes 35% efficacy. Whereas your natalizumab and alemtuzumab, it almost goes close to, natalizumab starts at 60-70% based on whether you're giving at 4 weeks or 6 weeks interval, and alemtuzumab goes up to 90% of efficacy. So that is the reason these are classified based on their efficacy as to higher level as well as lower level. And we should remember this when we are starting any patient of a multiple sclerosis. So take-home messages: assess the patient at baseline properly, rule out its mimics. It is very easy to tell it is MS, but most of the time, if you make a diagnosis of MS, I myself have seen many patients have been diagnosed as MS, and when they come to me and if I tell MS, they are not happy. Especially a few people, they are very happy with the diagnosis of MS. So assess the patient and make the diagnosis properly, rule out the mimics, and match the correct disease modifying agent with the correct patient. Thank you.
Thank you, Dr. Netra. It was a superb presentation. Very, very useful concepts you have given. I'm sure there will be a lot of questions to come up. You have mentioned that without treatment, the time to dependency is about 15 years on an average. With treatment, what is the time to dependency?
If we start early, see what I told about 80% is basically prior to when there were only interferons and glatirimab when they were there. That time they have tried to see the prognosis and they have found 15 to 20 years they become bedbound. But now that long-term studies are still going on, but they have found that if we have caught early and for nearly 2 years, if your EDSS is maintained, maybe over the next 5 to 10 years, they can still maintain at that level. That is a dictum. But if your EDSS, so one thing what I think I did not put up is we should not just be seeing the disability motor. We should also assess the cognitive as well as the behavior. No more MS is just a white matter lesion. That's the reason you have the atrophy which sets in. So it affects also the gray matter. So all the three things has to be assessed and then decide about the medications. But if we catch early, maybe even at the 10 years, the EDSS may be still maintained at less than 2 to 3 years. But if we catch it late and it becomes progressive and we are still giving a lower level DMA, then gradually they will worsen as well as go into a progressive form.
The reason why I asked is there is a Canadian study. As you know, Canadian system has a very nice, monitoring over long term. They found that though radiologically they do well, at the end of 15 years, there is no difference between the treated and the untreated groups. That is what the conclusion. So
I think that study was initially before all these highly active MS, especially when it was only with the interferons and the disease modifying. That's what I said, sir. It is only the lower level ones are there. But now with efficacy, in fact, when patient comes with MS, I always tell them that if we are catching them early, then it is good that they may still be able to live their life better.
Okay.
One more question. How to stop the medicine? When we decide to stop a disease modifying agent, if a patient is NIDA for 1 year, 2 year or 3 year, when do we stop? So all this immune modulator, again from myasthenia to this, we know when to start and what to start. Now at least we are a little more clear. But when to stop is the question.
Okay, I will take three things. One, if the patient wants to become pregnant and the patient's EDSS has been maintaining well for at least 2-3 years, then maybe we can give a short holiday, but it's again a holiday. It's not a complete stoppage. And then they can go about. But otherwise, if it's a RRMS and if there are only few studies which have addressed that at least for 5 years, if they are being almost, the NEDA has come down, EDSS is just less than 2 or even 1, then also we can try to stop. Few of them say, but that they have seen that if you have taken multiple immunosuppressants multiple disease modifying agents initially, especially natalizumab, and you've controlled the illness of 5 years, you stop it, again, they may flare up. So I think it is not just about the duration of illness that they have been maintaining. I think we have to take everything into category. So if you have to have multiple scenarios. You have a scenario where the MRI is looking good. It is not a high lesion load. Maybe at the end of 5 years, we can try out. But if it's a high lesion load, even if it's 5 years, we wouldn't want to stop the medication. But in a secondary progressive form, it is different. If we have tried out all the medications, nothing is helping, then they say you can stop. But in RRMS, I don't think we should be stopped.
Dr. Ratnavalli has raised one question about immune reconstitution therapy for MS.
Immune reconstitution, now we have with alemtuzumab, and even with the stem cell therapy, it can be done in few. Basically, what I did not mention about that, what happens is whenever we give a disease modifying agent, like for example, I'm starting the disease modifying agent in January 2020. So if it is natalizumab, its effect may be only till February. I'm starting rituximab in January, its effect will be till June. So at the end of their efficacy, when it goes away, you need to again give up one more medication dose. You need to supplement. That's the reason we have the doses which are given at 1 month, 6 months. That is because their efficacy goes up. So these are called as immune modulatory. Whereas immune reconstitution is, what happens is when we give, like alemtuzumab, when you give one therapy, it almost completely washes out almost all the B cells and only the progenitor cells will be there. So they come back, they repopulate. And when they repopulate, the repopulated B cells are supposed to be coming back with a better immune strategy. So where they are no more becoming autoimmune to their own body. So with that, maybe sometimes after 2 years with alemtuzumab immune reconstitution, around 60% of them may not require any other immunomodulation. That is 60%. So this is called immune reconstitution, where you try to reset. It is like formatting a computer, I would tell, where you try to reset the progenitor cells itself so that you have a better immune system, which is not like before, and they are better B cells so that they are not identifying as an autoimmune of your body, and MS condition is controlled. And that is approach that is possible by alemtuzumab and stem cell therapy.
Madam has also asked you about what do you think of autologous bone marrow transplantation in our setup?
I think both are good, but the market is only for the monoclonal antibodies. I'm sure no pharmaceutical companies will come forward for a stem cell therapy. That is the reason I think the stem cell therapy has not come up in the large setup, as well as it requires a team. There should be a neurologist, there should be that hemato-oncologist, as well as the radiologist, which will work as a team. So there are only few centers. I think Dr. Nasti Ichapuria has given in few conditions. I have not done. I'm only aware of him who has given stem cell therapy. And few places in North India, there are some 2 places where they have given stem cell therapy. And they have quoted in few conferences where there are small case series. Till now, I think less than 250 patients have been received stem cell therapy, and they have found efficacy among them. But we have more large number of patients with the disease modifying agents. I think one is because of the scared, one is because of the pharmaceutical companies, but both of them are. So if you remember my last slide where I put up the HSCT and alemtuzumab, both of them are in the higher list.
Okay. For the sake of residents, can you tell us, in a patient where the diagnosis is not very clear between MS and NMO, which drugs to be avoided? Some MS drugs can worsen the NMO. So
usually what happens is like the case which Rohit presented, where the patient has come to you with the first demyelinating episode. And that time you are not sure whether it is because of MS or your auto antibodies are showing few antibodies. So whether it is a APLA syndrome or a NMO-MOG disorder. If you have a good radiologist who is able to tell you, or if you have an MS specialist who can differentiate between this, it will be good. If not able to differentiate, even we also, many of the time we will not be able to differentiate, then give a medication which will be applicable to both. Like rituximab is one of the medication which will be helpful in almost all of these conditions. But if it is a CNS inflammatory condition like neurosarcoidosis, then there are only few conditions rituximab may or may not be helpful in that condition. But otherwise, NMO, MOG, MS, all of these will respond to rituximab. But there are few subset of MOG which will not respond to rituximab also. That also we should remember. So, but this we can start immediately, or sometimes the patient can't afford, we can start azathioprine, though it is not in the recommendation of MS or MS, but it is, there are a few studies which have been found that they can be helpful. So these can be used. But when you have a dilemma between MS and NMO, avoid interferons, glatiramer, dimethyl fumarate, teriflunomide, natalizumab. All this disease modifying agent will be avoided. So you will give something which will help both of them, like rituximab, azathioprine. Mycophenolate also can be given, but only because of its mutagenic and teratogenic potential, I did not mention.
One more
great
question
talk.
Yeah.
Sir,
Please go ahead.
Yeah. So great talk, Netravati.
Thanks.
So in terms of now orals being available so freely, the generics being available, so where do you see the role of interferons? They will still stay, or they'll be,
It's
taken
at least
off the
gone
market?
away. At Nimans, it's gone away already. I don't think we have any patients now on, because one of the thing is adherence. See how long they will go on taking every week, every alternate day, the injectables like interferon, glatiramer. With time, they actually develop a lot of side effects. The flushing with glatiramer is quite bad, that they go to the emergency. It will happen over 2 years. It will definitely happen. And the fever and the body pain and not being able to work for 2 days after taking the interferons, that itself reduces the adherence. So I remember when I started, especially with Satish Chandra sir, we used to explain so much to people about take dodo before giving interferon, everything, and we used to start Avonex, interferons and glatiramer, but now we are not seeing. And your question about generic, that we are using it. Few of the generics we are finding that it is helpful. Few we are not finding. I think only if we have a comparative studies, it will help us in telling.
And how do you, how are you deciding between going for dimethyl fumarate versus teriflunomide? I know there is dimethyl fumarate is a little bit more efficacious as compared to teriflunomide. So looking at the grade of the disease, or how's it?
Both of them will come in the same grade of the disease, but one thing is about the fertility and if they are in the childbearing age. I think that is the main thing which we have to take into consideration. If I find, this is one of the things which I would want to tell everyone, that if a man comes with multiple sclerosis, almost all medication can be given in the childbearing age except teriflunomide, because this one has effect in the fertility as well as having a child. But for a lady, others all will be a difficult. So teriflunomide is one of the things which will remain in the sperm, and that's the reason it will not be advised in a male population. Other than this, it will be mainly the reproductive age group. Nothing else. Both of them are in the same level. Maybe dimethyl fumarate I would rate a little bit better than.
Another thing about teriflunomide is it the adverse skin reactions and systemic responses. So that
tolerance.
Yeah.
Definitely that is lesser compared to dimethyl fumarate, but with the generic which has come, dimethyl fumarate, we are finding many reactions also happening. The original generic does not have so many side effects of dimethyl fumarate. So I think we have to take the cost factor as well as the fertility and the and then decide for these type of people. Otherwise, if cost is not a factor, I don't think we'll be giving these choices if the generic dimethyl fumarate or a generic teriflunomide.
Okay, I think there is no further question. I'll hand over to Dr. Raghu. Thank you, Dr. Netra, once again. It was a beautiful presentation.
Thank you, sir.
Thank you, Dr. Netra. It was a very good and lucid presentation. I think most of the basic things are covered. So I also thank Dr. Rohit, Dr. Rajesh Iyer, and Dr. Savit for their good talk, and Dr. Sharma for guiding this session very well and answering all the questions. So if no further things, I think I thank all the panelists also and the Hallmark for hosting this session without much hiccups. Thank you one and all.
Also thank Intas Pharma for supporting this webinar.
Yeah, sorry, I just forgot that. Yeah, without them, I don't think we can proceed. Yeah. I think Dr.
Thank you, Shivkumar from Intas. Thank you.
Thank you so much. Thank you.
Shivkumar, yeah, right.
Can we end, sir?
This was it. Sir has left.
ಅದು ಚೆನ್ನಾಗಾಯ್ತು ನಾನು ಲೇಟ್ ಆಗಿ ಒಪ್ಪಿಡಿ
Okay.
Surprisingly.
Can we end it, sir?
Okay. I'll talk to him on the phone.
Yeah.